sir.
Yeah. Good evening, everyone. Today I will be discussing on infections and ECMO. As Pranay said, this is very important topic for us because infections are the reason why ECMO is needed. Patients tend to get infections on ECMO. The side effects are multiple, as well as resistance tend to develop once you go on increasing uh, antibiotics one after other to most broad spectrum agents. So we will touch upon some of these aspects. This fact is true. I cannot teach anybody anything, but I can only make them think. This applies very much to today's talk. So I will give you the broad principles behind infection control, and I will ask you to think. The objectives are, we will talk about the infections during ECMO, what is the incidence and prevention, how can we do that, antibiotic stewardship, and the dosing. This slide means a lot to me since the existence of life on Earth, bacteria have appeared nearly some 2.5 billion years ago, whereas humans are still hundreds of thousands of years only, 200,000 years only. So, with that, we cannot ask the bacteria which have been here in this world for 2.5 billion years to disappear all of a sudden. It is not going to happen. So, just with that, probably coexistence is a better way of living together in case that is possible. We have friendly bacteria and pathogenic bacteria too. Friendly bacteria are very, very important for us for our survival, and with broad spectrum antibiotics, we are killing them too, besides the pathological bacteria. Have you ever heard of quorum sensing? Uh, I request you, once you go back, you look at quorum sensing and study that for an hour or so. It will be very interesting. Quorum sensing is the language through which bacteria communicate. It is a communicative mechanism by which they will transfer um, resistance factors from one species to the other, one organism to the other organism. So this is a very important uh, aspect of bacterial nature. Once we put our cannulae inside the patient, either it is ECMO cannulae or a central venous cannulae, biofilm is going to develop on it. Biofilm is growth of multiple bacteria, multiple numbers of bacteria which are covered by a slimy capsule. So antibiotics are not going to helpful in this region for getting rid of these bacteria. From time to time, maybe as a result of suctioning or movement or naturally, this once the biofilm gets liberated from the underlying surface on which it was there, it can cause infection, septicemia, bacteremia, etc. This could be the source of it. So we have to be very much aware of biofilms. Infection is the biggest enemy for us. It causes economic losses. It increases the morbidity and mortality, and our results could be much better without secondary infection. Currently, infection is responsible for 20 to 40% reduction in our survival rates. Why they are so important is because they decide the duration of ECMO. Once a new nosocomial infection sets in, the duration of ECMO gets extended by a week to 10 days. And I, uh, I don't need to tell you about how much will be the economical uh, effect as a result of extending the duration of ECMO by a week to 10 days. And nobody knows about it, what will happen at the end of this 1 week to 10 days? Is the patient going to succumb or is it going to get better? They remind us about the need for introspection of our policies and infections decide our success or failure. They are ever so important in countries. Infections tend to happen everywhere in the world, but they are ever so more important in our countries. It reminds us about hospital acquired infections also. So we have to take steps for preventing hospital acquired infections. Root cause analysis with open mind is very much necessary when you come across them. Use effective antibiotics for the right duration and prevent fungal infections. Currently, whenever we suspect infection, we do the following tests besides our clinical examination, which is suggestive of infection. If you can find a focus anywhere, um, the hematological investigations could be with full blood count as white cells, platelets, C-reactive protein, procalcitonin, blood cultures, etc. So with the white cells, platelets, CRP, procalcitonin, all of them uh, go up in the presence of infection, but also in inflammation. ECMO is an inflammatory process, putting the lines and everything. So as a result of this, also these numbers can go up to certain extent. So procalcitonin is a useful tool for excluding infection, but it is not very specific. Even it can go up in the presence of inflammation also. Blood cultures are um, very good when they come positive, you know the organism, but you have to take measures how to get positive blood cultures, true positive blood cultures, by avoiding contamination. So that is very important. Historically, only 50% of the instances we can have positive cultures. These infection rate, prevalence, and various numbers like full blood counts and neutrophilic response, etc., they have been recorded in ELSO registry uh, for the past 50 years. This is part of the data we submit to the ELSO registry. So here this slide shows about the incidence of infections in the ELSO registry data in different populations: neonatal, pediatric, adult, pediatric VA and adult VA, etc. So you can see them, it's a varying number: 4.9 in neonatal, 13.8 and 15.2. From here it looks it is a higher percentage in in the adult or adolescent population compared to neonatal population. White cell count less than 1500 is also being recorded. Again, similar sort of results here also. More in adult, the incidence is more in adults and pediatrics compared to neonates here. So, here the incidence of viral pneumonia, bacterial pneumonia, pneumocystis, and aspiration pneumonia have been recorded in various age groups, that is pediatric and adult respiratory runs, you can see here. Routine circuit cultures and prophylactic antibiotics are not indicated beyond treating an underlying infection. So we practiced routine cultures nearly 20 years ago, and we found it is not going to be very useful, and we discontinued since then. Prophylactic antibiotics, similarly, in India, most of us will be worried about catching an infection, but my plea to you is make sure uh, we include we improve the underlying environment, the micro environment, and reduce our dependence on prophylactic antibiotics. Certain procedures and practices, such as giving a thorough wash with chlorhexidine once or twice before cannulating, will reduce the incidence of bacteremia at the time of line insertion significantly. But it has to be like a thorough scrub, not like simply putting some chlorhexidine and washing it off. It should not be like that. It has to be a thorough scrub. Mortality in ECMO cases has gone up by 30 to 40% in Indian scenario. ECMO duration will increase by 1 to 10 days, as I mentioned. Multi-drug resistant flora will develop with their after effects on multi-system failure. This is when we did the study in 2017. There is a need for further studies. Unfortunately, people do not want to come forward thinking that they will be laughed at when you present the true data regarding infection or what is the mortality, morbidity as a result of infection. I think that is not true. We are all learning, so it is better to educate each other by presenting the true picture of infection in our country. So it gives us a scope for uh, making us better. There is a need for publication of more uh, evidence on infection, the type of bacteria, fungi, antibiotic profile, these things we need to know. Common organisms are gram negative, gram positive in that order, followed by fungi. Multi drug resistant strains we have all seen. Uh, Remember, all the patients with MDR do not die, only certain patients die. Viruses are another reason why people may need to go on to ECMO. The risk factors are ventilator associated pneumonias, bloodstream associated infections, and catheter related infections as well. It varies with the ICU protocols and antibiotic prescription policies. In risk factors, as I mean, this study, when procedures were performed for more than 148 hours in 139 patients, 36 patients had a total of 46 infections. So their conclusion by Cecil et al. Was adult patients who undergo ECMO are at a greater risk for developing a nosocomial infection and sepsis uh, in neonates and children is less than what it is in adults. Adults 20.5%, whereas in neonates 6.1%. These are the various bacteria which Cecil et al. Came across and also reported by Ram Gopal Krishnan et al. Infections during ECMO, the time duration of ECMO is directly proportional to the incidence of infections on ECMO. The longer the time a patient spends on ECMO, the higher is the incidence of infection. This is from ELSO data. Nosocomial infection in adult patients again is showing the same thing. Beyond 12 days here, incidence of infection has gone up to 100% over there. So the longer they spend on ECMO, more will be the possibility of infection. Hospital acquired infections in ECMO is 10 to 12% in Stefano et al. Study. Their occurrence is likely to be more frequent compared with other critically ill patients. So ECMO group has a higher incidence of uh, bacterial infections compared to a similar group of critically ill patients. Coagulase negative staphylococci, candida, enterobacteriaceae, and pseudomonas are the most frequently involved pathogens. A high incidence of ventilator associated pneumonia was reported with a major role unexpectedly played by Enterobacteriaceae. So the gram negative organisms are gaining prominence nowadays. It is a worldwide phenomenon. More are so common in India as well, but it is a worldwide phenomenon. COVID-19 patients were vulnerable to invasive fungal infections such as invasive aspergillosis and invasive candidiasis. They were found in 22% of patients in one study in the postmortem studies, 1 in 3 cases in postmortem studies. The incidence of invasive fungal infections is underdiagnosed, underreported as more cases were reported in postmortem series. Given the scarcity of PM studies in our ECMO patients in our country, we will never know the true incidence of fungemia in our patients. So, This recommendation by Mehrnaz et al. Shows echinocandins, voriconazole, and isoconazole are recommended as the first line treatment option for COVID associated pulmonary aspergillosis. From American Society of Infectious Diseases Society of America guidelines, echinocandin is the recommended first line therapy for candida associated bloodstream infections. Liposomal amphotericin B is recommended in case of suspected or confirmed azole resistance. How do you prevent infections? Old principles are still like gold standard. Washing hands thoroughly in the way described, recommended for all of us, involving all the steps, is very much needed. Using clean water and soap, or using clean water and chlorhexidine. From the days of William Osler, the importance of hand washing has been emphasized. Soap, water, and common sense are the best antiseptics. We have found alcohol with chlorhexidine is best, and alcohol without chlorhexidine is the next alternative for cleaning hands if they are not contaminated. Chlorhexidine is a good agent, 2% to 4%. Then comes the role of povidone with iodine, 7.5% povidone, and triclosan as the last. So I'm sure most of our units will be using chlorhexidine, and that is a good agent for uh, clearing the bacteria and reducing the bacterial load. Superbugs, they do exist all over the world. Unfortunately, we were labeled as the initiating point of New Delhi metallo beta lactamase 1 strain, NDM strain, uh, but they do exist all over the world. It is a known fact. It is not surprising to know that the water we consume, the water that is supplied to all of us, contains these drug resistant bacteria. They are there in the water, they are there in the soil, and there are enough studies showing that they are ubiquitous. To get rid of this bacteria from the running water, the tap water has to be subjected to reverse osmosis process. In every hospital, water treated by reverse osmosis is supplied to all the operation theaters. It is not a must. Uh, in our intensive care units are supplied with water treated by reverse osmosis. Please make sure this is very important. You don't want to wash your hands with contaminated water and give these infections to the patients. Operation theaters are important, so are intensive care units too. So we should be supplied with reverse osmosis treated water. There are some subtle things such as active ingredient of the drug, how much is it, or what are the drug levels. We do drug levels, but not very often in India. Toxicity wise, hepatotoxicity, nephrotoxicity, etc., they have to be considered. De escalation is the most important aspect we tend to underdo in most of the circumstances. Once an antibiotic is on, it will be continued forever. My request is, as per the antibiotic stewardship guidelines, use the antibiotics depending on the need. Septicemia, bacteremia, meningitis, whatever. A week, 10 days, 2 weeks, etc. But stop the antibiotic at that time. Otherwise, resistance will develop for sure. Multi drug resistant bacteria will develop if you are continuing the antibiotic. Even fungemia also tends to develop with that. So fungal prophylaxis with fluconazole or on a ECMO patients, as we learnt earlier in COVID patients, like echinocandin could be the first line of treatment for suspected fungemia. Uh, in neonates, for example, if you consider uh, how do we prepare our antibiotics, so this colistin vial contains 150 milligrams. It might last for a week of supply or if not more for a neonate. So we tend to continue using it on the name of the same patient for 1 week or 10 days. Actually, after 24 hours of dilution, the efficacy will be lost. So those minor things, how long it remains potent after reconstitution, those are the things to be monitored as well. We feel like we are giving the antibiotic, but actually they are not getting the antibiotic because of subtle reasons like this, which we tend to forget. In Krishna Institute of Medical Sciences, we tend to have hand rub at each and every bed. No one is allowed to touch the patient without applying hand rub to their hands. So that is very important. And also, it was a practice there to use sterile gauze like this, wrapping the central lines. At least it gives you an idea like you are accessing a very important site. So unless you wear gloves, you don't touch that area. So it gives you that notion it is a protected area. And without knowing, sometimes you can see the residual left in a suction pump over there, and bacteria tends to multiply in that. So these things to be avoided. Another small thing is, when we do echocardiography, we take the probes, we take the machine, do the echocardiography because it shouldn't be sterilized with alcohol. We mop it with the intended mop, and just to put it back here. So there is every possibility for transferring infections from one person to other person with this. What I suggest is, if you take a glove, the ordinary glove, put some gel in that and put this as a cover for the echo probe, and do echo with the um, probe having cover of um, ordinary glove. Okay, there should be gel inside the ordinary glove as well, just covering the surface of the probe, echocardiography probe. So once your examination is over, pull the cover off, throw it off, and you can clean your echo probe. So that keeps your probe relatively clean compared to when you directly apply to the skin surface and do not clean it sufficiently. These are the regular surfaces which we touch many times during the course of a day, like syringes, etc. They have to be cleaned at least in every shift. Such low intervention devices, such as using a plastic apron, prevents you from coming into direct touch with the patient bed and carrying infection from the patient bed to another patient and to your home. So this costs around 1 to 2 rupees per sheet. So these type of things are very very useful before anyone touches a patient. Using an ordinary glove, I'm talking about the sterile glove, but an ordinary glove like this also costs around 2 rupees per glove. Before examining a patient, whoever touches and examine the patient, if you wear the glove and throw it off after examination, then you will be reducing the chances of infection, and you don't carry infection from patient to patient. So this has proven to be reduced, reducing the incidence rate of infection by 25%. For example, in this case, some of our colleagues, they did the dressing and they left the uh, in these gauze pieces next to the patient over there. They were drenched in blood, and they may be carrying bacteria as well, but they are just left over there. So as they were not sufficiently disposed of, and they are still staying on the bed surface, if somebody going and leaning onto this is likely to get infected, and they will can carry on the infection to the other places also. So rethink about the ways we are functioning with respect to preventing infection in our country. Modification of our behavior is very much needed. We need to work at a cost. And to me, physicians' will is the most important thing in treating infection and avoiding antibiotic abuse, preventing resistance bugs from developing. I cannot emphasize more about the importance of antibiotic stewardship. We have to address that again and again, and please follow all the principles. The dosing of antibiotics wise, broad spectrum antibiotics are common to be started on any patient in any ICU when you suspect infection. We all agree with that, but be guided by the results of infection screening you send, and de-escalate and modify antibiotics as per the culture results. Differentiate between the commensals and pathogens. Don't treat the commensals and treat the pathogens. Sometimes the division is difficult, but try to use your knowledge in differentiating commensals from pathogens. Narrow spectrum antibiotics for the right period, and appropriate dose of antibiotics as assessed by pharmacokinetic and pharmacodynamic studies and the drug levels. So the key here is the de-escalation of antibiotics once the need is done. People have tried using cytosorb, um, but the cost factor here is prohibitive. In case cost is not a problem for you, in case of florid sepsis, one can try cytosorb too. It has been tried more often in adult studies than in pediatric studies. So cost is the most important problem. May or may not help. Circuit change, similarly, um, we don't recommend changing the circuit or oxygenator for the sake of infection, because these are the bacteria which are there in the patient. Once you start the next circuit or oxygenator, the same bacteria are going to get colonized onto this circuit as well. It is unfortunate, but we tend to concentrate on treating the infection rather than changing the circuit or the oxygenator. There may be exceptions, but generally we tend not to change the circuit or oxygenator as a result of infection. The usual antibiotics, I will leave it to you because it changes from hospital to hospital and the bacteria prevalent in your intensive care unit. From my understanding, the bacteria could be different in medical ICU to surgical ICU to pediatric ICU to neonatal ICU. It all depends on your antibiotic control policies and the different antibiotics you prescribe on them. How do you look after your aseptic principles, etc. So I don't believe a hospital has a special antibiotic flora. It is each and every ICU as a common environment shared over there. They will have a pattern of commensals which are staying in that ICU, and their particular sensitivity patterns. So I will leave it to you for decide your own bacteria depending on the prevalence of what sort of bacteria and fungi you are getting in your environment, and be guided by that regarding the antibiotic choices. Just a couple of slides on the antimicrobial surfaces. Microorganisms are known to survive on non antimicrobial inanimate touch surfaces such as bed rails, over the bed trays, call buttons, bathroom hardware, etc., whichever the patient uses for extended periods of time. Studies have shown copper, if these surfaces are made of copper, it kills the bacteria, viruses, and fungi to the extent of 99% in an hour's time. But using copper instead of steel is financially a difficult option if centers want to build their units at a cheaper cost. But those units who have used this principle and used copper material in all the equipment which is used for the patient as far as possible, then they found the infection rate to be much less. So, just by using copper, the rate of your infections is going to come down, cross contamination is going to come down, antibiotics you are using will be less, and resistance will be less as well. Ultimately, use the interventions as a bundle, not on its own. Hand washing on its own doesn't help. Hand washing plus maintaining antibiotic stewardship guidelines, using gloves, meticulous way of examining the patient and disposing of your sterile gloves, making sure your nurse is in charge of anyone touching the patient or disposing of the infected material, etc. These things, whatever may be their cadre, but your nurse should be empowered and they should be supported by you. No blame culture is extremely important. Otherwise, we cannot make progress in this game. So, I cannot overemphasize the importance of staff education. Specify the staff for duties and responsibilities. Education is a matter of continuity. Train under the senior's observation and train the staff with scientific goals. Review your own situation openly, understand the lacunae, tighten the loopholes leading to further advances. Everyone in the team is important, including class 4 employees and the Aya, as you see in this picture. They do a lot of good work by cleaning the surfaces very frequently. They will never get appreciation, but in fact, they are a huge role responsible for limiting the spread of bacteria in our units. For me, standing in the corner of the ICU and observing how different colleagues are performing uh, used to tell a lot about what are the corrective steps to be taken in that particular circumstances in my unit. This is again with no blame policy. I'm not after them. Maybe subconsciously they are doing something, but it is a fact. So we have to acknowledge that and try to change it if it is affecting your infection control policy. So the take home message is hand hygiene is very important. Make sure your microenvironment is free of infection. Then you are allowed to play with your antibiotics by minimizing the antibiotics, or everything you can do about narrow spectrum antibiotics for the desired duration, etc. But your microenvironment, this is the most important factor. First you can change it. I tried, I was able to change it within a period of 3 months. This is not a permanent way of treating infections either, or preventing infections either. They tend to come back, but again, have a decent introspection about what has gone wrong, where things went wrong, and try to correct them again. Changing the way we do things has to be closely looked at. Antibiotic de-escalation is a policy. In UK, certainly there were periods when we were running the circuit without antibiotic, if infection is not the problem. No blame culture, examining cost effectiveness interventions and using interventions as bundles is very important. My final plea is, if you think in your hospital, operation theater is the place where infections do not go and meticulous antisepsis is practiced over there, why can't your why can't you make your units like operation theaters? Thank you very much. This is my last slide. If there are any questions,